Hello, and welcome to episode 39 of the Carry On with Carrie podcast. Today, I had the pleasure of talking to Lisa Rowbottom. Lisa is such a genuine and caring person. Lisa believes that everyone deserves to live an authentic and fulfilling life. Her experience is working with a variety of different clients, including those with intellectual disabilities, autism, and fetal alcohol spectrum disorder. For several years, Lisa has worked as a psychologist with Alberta Health Services in the mental health hospital. Today, she is now with Soujourn Wellness, and some of her treatment methods are surrounded around personal-centered therapy, cognitive behavioral therapy, Mindfulness Base Approaches, EMDR, harm reduction, solution focused. She's got so many different things that she's working on. She helps treatment focuses with anxiety, depression, mental health diagnosed individuals, family support systems, and individuals with mental health. She works with grief, OCD, trauma, stress management, self-esteem, clergy and Christian counseling on request, and addictions. So yeah, the list goes on. Lisa is full of so much amazing information, really. We could talk all day. And I know you're going to get a lot out of this episode. I always say that, but it's true. I really hope you enjoy. So sit back, and now it's time to talk. Hello, and welcome to episode 39 of the Carry On with Carrie podcast. Today, I am thrilled to introduce you to my guest, Lisa Rowbottom. She is a registered psychologist, M.E.d. Can you explain to the listeners a little bit about your background and what got you interested in this area of psychology?
Okay. So what really got me interested in psychology to begin with was a few things. So I have adopted sisters who have fetal alcohol spectrum disorder. And I think my interest really started there because I really started seeing some of the differences and how the brain worked. And, so that kind of got my interest going. And then from there, I spent a lot of years working with people with developmental disabilities, developmental delays, intellectual disabilities. And that's actually probably my favorite population to work with.
Okay.
So I was working with those individuals while I was going through my schooling.
Mm-hmm.
And I have a master's in counseling psychology from the U of A. So the reason it's an M.E.d is because it's out of their education department. So it ends up being an M.E.d.
Yep.
Yeah. Confuses people sometimes. And then after that, I started work out at Alberta Hospital. So that was kind of my first psychology job there. And I was there for 10 years. And I worked through quite a few different units. So I worked with people who were resistant to treatment for a variety of mental illnesses, so schizophrenia, bipolar, the more severe versions of certain things. I worked with people on the intellectual disabilities unit,
Mm-hmm.
and then I also worked with people on a unit that's more transitional. So they would have finished a program in one area of the hospital and would be transferred there to wait for placement or for funding or something like that.
Mm-hmm.
So it gave them things to do and activities just to keep them busy. And then after that, I left there after COVID. So I worked there through COVID. But I had also started working here at Soujourn part-time in the evenings.
Okay.
And then after COVID, I was ready for a change. Because that job does take a lot out of you.
I was going to ask, how was that experience, especially with the schizophrenia, the bipolar? Can you kind of give a little bit of insight as to what that atmosphere is like?
Well, I have to say I did absolutely love my clients
Mm-hmm.
or my patients there.
Yeah.
They were some of the most unique and interesting people. And when you really sat down with them, they had some amazing stories about, traveling they'd done or what their life was like before they got sick or, even just their perspective of the world was really interesting. And so still to this day, I think back to clients that I had and I miss
Mm-hmm.
them.
Oh, yeah.
But it's interesting because when you're dealing with treatment resistance, well, all of the units required a certain modification to the techniques that I use.
Yeah.
Because when you're working with intellectual disabilities, you have to make it understandable.
Mm-hmm.
And when you're working with treatment-resistant individuals, it's kind of like water on stone.
Okay.
Because it takes a long time to see any change or any movement. So you have to just keep at it and at it and at it.
Mm-hmm.
And, as a psychologist, it's a challenge when you're not seeing any sort of movement.
Right. I can imagine that would be definitely sometimes discouraging.
Yeah, sometimes. Yeah. But, every once in a while, then you'd see something major happen and it'd be like, okay, this is all worthwhile.
Right.
And then you're back and you've got, stuff to give to keep going.
Right.
I think that, the atmosphere in the hospital itself, generally we tried to keep it as light and as sunny as possible. If you think about any sort of hospital unit that you would really go to in the city, if you're visiting a loved one, you're going to, say, the Grey Nuns, there's a hospital unit there. They're very much laid out that way.
Mm-hmm.
There's a nurse's station, the different rooms off the side. Some people would end up with roommates. Some people wouldn't. It really depended on what somebody needed.
Mm-hmm.
We tried to be as sensitive to that as possible.
Right.
And then they would spend their days going through programming. So there'd be breakfast in the morning, and then, we do groups and activities. And we kind of alternated between psychological treatment and more day-to-day living skills.
Right.
Because when you're dealing with someone with a long-term chronic illness, a lot of the times, they've started to lose some of those skills.
Right.
And so, we teach them that. And, they had a kitchen there. So we'd go teach them how to make, like, eggs on toast or something.
Mm-hmm. Yeah.
Or, we'd go out somewhere, or they have little shops kind of tucked in around the hospital that lets the patients get some work experience, as well as for us to teach patients, especially the ones with developmental disabilities,
mm-hmm.
To teach them to handle their money,
Right.
or, how do you figure out how much you need back? So it worked both ways, because it let them gain some work experience as well.
Right.
So people that functioned a little higher or needed to add something to their resume, they could do that.
Mm-hmm.
Well, on the other side, we could teach. So
so that, because we were talking about that before we started recording, is just a little bit of like the Hollywood misconceptions about facilities, and how that needs to be changed.
Yeah, it's nothing like you've seen in the movies at all. Yeah. You wouldn't know you are not in any other hospital, except that the patients are in their regular clothes. Mm-hmm. So they're not walking around in patient scrubs and things.
Right.
Most of the staff there just dress as normal staff would. Mm-hmm. So the nurses are still in their scrubs, but as far as like the psychiatric aides and all of the other support staff, we're all just in regular day-to-day clothes.
Yeah.
So we didn't make distinctions that way. Mm-hmm. And then the grounds at Alberta Hospital are beautiful.
Oh, they are beautiful.
So we'd get out a lot
like a
and
park.
Do that. Yeah.
Yeah, lots of walking, and it's a huge, almost campus.
Yeah, it is. And I think too, like, we also made space for any sort of religious practices too. So there's a chaplain there, and there's a chapel that people use for a variety of things. So people who are practicing Muslims, they would have someone come in and do prayers.
Okay.
There would be Catholic services, and there's, more just general services. Mm-hmm. And then for people who are Indigenous, we had spaces for them to do or host a sweat lodge, for example.
I didn't know that.
Yeah. Mm-hmm. There's an elder that would come up and visit the patients periodically as well. So we did the best we could to connect them with whatever culture was important to them.
Right. Yeah.
Because that was helping them make space for themselves in the community was a big part of it, mm-hmm. because they need that kind of community support and they need to feel connected.
Yeah.
And a lot of times they don't.
Exactly. And if there's that spirituality, sometimes, no matter in which form it takes, that mm-hmm. can make a big difference to somebody.
Yeah, absolutely. And just the concept of a higher power for people who are struggling with some very severe mental illnesses somehow seems to bring them some level of calm.
Yeah, I mean, they're not alone, right? It gives them that feeling. Now, and were you ever a part of the addictions center at Alberta Hospital? Did you work with that at all?
I wasn't part of the addiction center, but I did do a lot of addictions work in terms of some of the clients or the patients on the units that I was on.
Okay.
Some of them there had pretty major drug issues, and because of where the drug use had gotten them to, they weren't necessarily able to participate in the average or the regular addictions program, if there is such a thing. So they needed more specialized, individualized work. So I would do that with them.
I've heard that schizophrenia, things like that, can be brought on by drug use. Did you see a lot of that you would get psychoses starting because of drug use?
Yeah, absolutely. I think those were the hardest because they would become very, very ill, sometimes to the point where they couldn't carry on an understandable conversation with you. But knowing that that was not natural or part of their genetic makeup, that here was a life that would have been perfectly healthy and normal, but they, because of the choices they made to use, they use to the extent where their brain can't recover anymore. And so they would end up with substance-induced psychosis is what it's called. So basically you've got the hallucinations and the delusions that come with that. And then you get the inability to even converse about anything because they can't carry a conversation, and people lose them and it doesn't make sense. And and a lot of isolation, because often by the time the person gets to that point, the family is exhausted. And so there tends to be a lot of distance between the family and the individual in the hospital because the family just needs a break.
Right. They've gotten to that point and somebody's taking care of them so they can take a step back. But in that, definitely somebody, you just don't think about those sides of it. You know?
No, absolutely. And I think the thing with schizophrenia that you often hear, if you have the gene for schizophrenia and you can trigger it, even with just marijuana.
Okay.
But you have to have the gene. So people always say, oh, well, I used and nothing's happened to me. And that's great. You don't have the gene for it, so nothing necessarily will. But because schizophrenia is heritable, if somebody in your immediate family or someone in, your mom's side of the family or your dad's side of the family, like your grandparents and your cousins and that has it, then it's not worth the risk.
Yeah, no, don't even go down that road.
Don't even go there.
Yeah.
Because it only takes once.
Right. And that's why knowing your lineage sometimes is so important, to know the background and the history. And is there any testing for things like that?
Genetic testing
that way?
I don't think we've quite got there yet. So they've started identifying genetically sort of which types of medications are going to work best. So in certain hospitals or in certain situations, they can run a blood test and they can tell you this combination of medications is going to work, these ones aren't. So we're kind of gotten that far. But the thing with isolating a gene to any sort of mental illness is that there's nothing that is 100% heritable. The closest thing we have is ADHD. It's probably the highest heritability. And so, for example, like with something like autism, we can say, well, it usually passes down the male lineage. But we can't say, it's this gene on this part. And so we can find it and then we can, tick it off. It's like probably a few different combinations.
Yeah. And it's still kind of like a Russian roulette, really, in a way. I don't know if that's the right way to put it,
but no, it is. It really is. If you have somebody, who has a mental illness in your family, it is a risk.
It is becoming more common knowledge.
Yeah,
because it is talked about now, right?
Yeah, there's a bit of a controversy over kind of exactly how to deliver that kind of information.
Right.
I actually used to work with one of the individuals who was drafting or working with the government to draft some of the guidelines for marijuana usage. before they legalized it. And, there's different findings on different things, like does it actually affect the developing brain? Well, yes, we know that. How bad? We can't exactly agree. Does it always cause schizophrenia to show up if you use it, if you have the gene? Well, not necessarily.
Right.
So we can't put out a statement that says marijuana causes.
No, exactly.
And
a warning that it's a possibility.
Oh yeah.
Yeah.
And the challenge with that is if you can't at least show a strong correlation, if not causality, is that people will always notice but sometimes it doesn't. And that's where their focus is. And so they miss the...
Yeah. And then comes the argument of, well, alcohol was legal way before.
Yeah.
And so then there's that whole thing too, though. And I guess it would be an interesting thing I don't know if you know much about it too, but you mentioned fetal alcohol syndrome.
Yeah.
Is there any proof as far as weed and any effects on babies?
Not that we have. I mean, it can do things like, cause premature birth.
Right.
But it's, sometimes there's some anxiety stuff.
But it's not a big,
Yeah, it's not as bad as alcohol. Like alcohol and meth are probably the two that have been flagged as being the very worst. Like obviously cocaine is not good either.
Right.
But when you're talking about kind of the worst case scenarios, it's usually alcohol and meth that cause that.
Right. It's crazy when you hear those two together.
Oh yeah.
And alcohol is used and it's so accepted in the society. But if you were to say I do meth,
yeah.
Right?
Well, it's interesting to think about because I often will talk to people who use about that.
Yeah.
And, we'll talk about how, there's addictions that are socially acceptable and there are addictions that are not. You just happen to have one of the ones that are not.
Right.
At some point, we could have decided that meth was perfectly okay. So then you would have a socially acceptable addiction, just like when we decided alcohol was perfectly okay.
Yeah.
It's a matter of social place and social stigma. And unfortunately, there's some areas that things should be seen as a little more dangerous than they are. And some things need to be seen as, maybe a little less dangerous than they're portrayed.
Yeah, exactly. So, okay, I wanted to hear more about some of the therapies that you now offer now that you're here at Soujourn, and a little bit about how was your transition from a atmosphere at Alberta Hospital to this is a lovely building, by the way. I get the chance to be here tonight. So
it was a transition. It took me a little while to get used to. There's just something about going from being paid by Alberta Health Services to being paid privately that all of a sudden it's like there's that little bit of imposter syndrome. Even though I'd been practicing for 10 years, I'm like, oh my goodness, they're paying me for this now. And I mean, I had trained in all sorts of things. Like it wasn't like I was new, but I had a few moments, probably about 6 months of that. I think I drove one of the other psychologists here crazy for the first little bit. But then it's much more hopeful. So people come in and you offer them what you can. And, very rarely are you going to find one psychologist who can offer you everything.
Right.
We all have our areas of expertise, our ways of working. I always tell new clients, especially if they've never seen a psychologist before, after our first session, I'll say, if you decide to work with me, because you need to know not every psychologist is the best fit for every client. So if I'm not the best fit for you, don't walk away going, well, psychology's not for me. It's just, it might just be, we don't click for whatever reason. And so try somebody else.
Right.
Because
it's a good or bad, you can have a good relationship or you just don't connect.
Yeah. You just don't connect. Or like, maybe I'm more of a future focused, present focused psychologist and you want to work more on, your past or whatever. And so if that's the direction you want to go and I'm working forward, it's not going to be a good fit.
Right. Yeah, exactly.
And so you need someone who does more childhood work. As far as areas that I work in, I have a couple of things that I do. I'm expanding gradually into a few others.
Okay.
I have a pretty strong background in cognitive behavioral therapy. That's something that the healthcare system really likes because they can kind of guess how many sessions you're going to have. And, they like numbers and, they want to like quantify everything.
Yeah.
And so they tend to like that. So I have a bit of a stronger background in that. I do really identify with the theory behind it, which is very much your thoughts and your behaviors can change your emotions, but you can't actively change your own emotion. I can't just tell you to, feel happy right now. Just go for it.
Right.
You can't.
No.
But I could say, well, think about like your best vacation ever and tell me about what it was like. And, we could really get into it and your mood's going to start to shift. Or I could say, go out and run around the block 4 times.
Yeah.
And your mood will start to shift, because there's actually a really big correlation between mood improvement and exercise.
Right.
As much as those of us who are not exercise people
yeah.
would really like to pretend that that's not the case.
Yeah, I know. Damn it.
I know, hey? So I identify with that kind of a setup. And I like the way that it starts out with some problem solving right off the bat, because when people come in, they're very rarely, some are, but they're very rarely saying, I was just thinking the other day that maybe I needed to, dig into my past and just find some things. People come in with something that's presently a problem. And a lot of times people don't have the time to dig back into things and like find the root of it right away and all of that. Sometimes they need like a solution right now.
Right.
I need something to do tomorrow. So I like the CBT for that.
Okay.
The only challenge with it is that it has a lot of homework. And if you don't do your homework, it's not going to work. And, people are not very good at doing
they want
their
you
homework.
to fix them.
Yeah, they want to do the work here and then they just want to go home.
Yeah.
So if you follow through and do the homework, then you're going to get the benefit from it.
Yeah.
If you don't, then maybe you'll get some, but you'll not get as much as you could.
And what kind of homework is it really? Like, it's about answering some hard questions about yourself and,
it's a lot of, journaling or recording your thoughts, or there's some very specifically structured worksheets to help you work through and rebalance your thinking, reassess what you're thinking. It really falls into more of the logic piece.
Okay.
Because the idea, and this is something actually from a different modality that I use sometimes, is that we have a logical part of our brain and we have an emotional part of our brain. And ideally, we want to operate where both of those are involved about equally. But for most of us, we get dragged over into the emotional part of our brain too far.
Right.
And so we need to start practicing letting our logical brain kind of pull us back towards the middle.
Right.
But the only way to do that is practice and practice and practice. So if I give you an exercise and you go home and you do it once and then you come back and say it didn't work, well, yeah,
probably not.
Probably not.
Yeah.
It's changing a habit,
yeah,
a pretty entrenched one. So it's going to take work to build on that.
Right. It took a while to get there, so it's going to take a little bit to get back out of it, right?
Yeah.
Yeah.
Absolutely. So I do that one. I have an interest in personality disorders just in general.
Okay.
So I've done the dialectical behavioral therapy training. I'm not licensed in it, but I've trained in the modality. So I use pieces of it here and there, or I will do a lot of the program with somebody who has a diagnosed personality disorder.
Right.
And it's very similar to cognitive behavioral therapy. It just is much more of a structured program specifically for borderline personality disorders, what gets the best results.
Okay. And so is there a basic kind of premise behind dialectical? Like what would be?
Yeah. So a dialectic is the ability to hold two opposing concepts as true at the same time.
Okay.
So I can like who I am as a person, and I can also know I need to change some things. Those can both be true, even though they're contradictory. And so what that therapy does is it starts teaching people to really look into their thought processes, their problem-solving processes, the automatic behaviors that they engage in, and really start questioning, is this helpful to me? So there's a lot of behavioral components to it. All of the handouts on how to check the facts, and then it's a whole bunch of questions. It also starts working on the very black and white thinking that personality disorders in general have.
Okay.
And that's where your dialectic piece comes in, where it's it doesn't have to be either or. Mm-hmm. It can be both. So you don't have to love or hate someone. You may just decide to tolerate them.
Right.
And so you're starting to loosen that up a bit as well.
Okay.
It goes through 4 different categories. So it starts out with mindfulness, and then it goes to emotion regulation, distress tolerance, and then interpersonal skills.
Okay.
So each unit targets those very specifically. Mm-hmm. To do the full program as it's meant to be done, you should have a therapy group as well as see an individual therapist.
Okay.
So it's quite intensive.
Mm-hmm.
But I do find the techniques in and of themselves are useful for everyday other people too, even if you don't have a personality disorder.
Can you tell us what a personality disorder is?
Sure, yeah. It's personality disorder is it's like there's an imbalance in the individual, or even just a reliance on one particular trait. We do know there's a strong genetic correlation there. Mm-hmm. We used to think it was trauma related, but when you really get into the research, there's strong enough genetic correlation that we're pretty sure there's something passing down.
Okay.
But basically, most of us have a variety of traits or a variety of characteristics we can switch between. So, let's say I have a meeting with my boss, and so I can move into more of a submissive trait. Mm-hmm. So I'm listening, I'm taking in information. I'm not going to necessarily try and dominate the conversation or convince them they're wrong, because, this is my boss. This is what's expected. However, I could leave there. I could go to a group of people that then I supervise, and I swap into a more dominant trait. So now I'm telling them what to do. I'm giving them direction. Mm-hmm. I may go from, even just more of a loving, caring trait to, a tolerance mm-hmm. trait.
Right.
You can switch between humility and pride or self-assurance, mm-hmm, mm-hmm. depending on your situation.
Right.
And we have a whole collection of these that most of us switch in between every day mm-hmm. without even realizing it. We don't think about it.
Yeah.
But with a personality disorder, they have one dominant trait, one way of being, and mm-hmm. that's it.
Okay.
And so if you think about something like, say, narcissism, mm-hmm. their dominant trait is over self-confidence or arrogance, one could potentially say.
Right.
That's what they use to interact with the world out of all the time. Mm-hmm. And this creates all kinds of issues for them, because, you can't have that trait in every environment and have people be okay with that.
Mm-hmm. Yeah, you're going to meet definitely going to meet some conflict there. And having said that, we talked about how there are those buzzwords right now, and I've talked about this in past podcasts about, narcissism is kind of a fad right now. Everybody's a narcissist, but like you said, everybody has certain traits. It's kind of nice to know. You just made it very like a click right there in thinking, okay, well, it's a dominant trait. It's something somebody has all the time, or more prevalent.
Yeah. The more that you interact with and work with people who have that diagnosis, there's some very predictable things that you see. Mm-hmm. So I've worked with it to the point that when I sit down with somebody, even if they don't tell me they're diagnosed, within 2 sessions, I can tell you at least there's something personality related because of the way they talk.
Right.
They're very outward focused. They're very predictable in kind of the things that are bothering them. In relationships, it runs a very predictable course. Mm-hmm. And so, yes, we might talk about people being narcissists, but every human characteristic occurs on a spectrum. And so we all have to have a certain amount of narcissism, because otherwise we'd have a lot of problems. Mm-hmm. So, to apply for a job, you have to see or feel that you have the the ability to do that job,
Mhm.
or you'd never apply. That could be considered self-confidence or a version of narcissism.
Right. So is it sort of a protection then?
Yeah, to a degree. For us in general, it's a level of self-interest. We need to keep ourselves alive and healthy.
Right. Yeah.
And if you don't have enough, often those are the people who are needlessly over self-sacrificing to their own detriment.
Yes.
And so, then you need to kind of build that up. And we have different words for it in kind of the pop culture. Like psychologists might say, yeah, that's narcissism, but we might say self-confidence or confidence or, an understanding of what your ability is. Like we have a lot of nicer words for it.
Right. And there can also be a self-confidence, and that's okay too. Are there any other buzzwords out there right now that you find dangerous on the internet, on social media?
Actually, I think the one that drives me crazy, to be honest, is when they say psycho. People are psycho.
Yeah.
They tend to translate that into psychotic, but actually what they're looking for is probably, psychopathological.
Okay.
So like a psychopath versus somebody who's psychotic, because a person who's psychotic is delusional or is having hallucinations. And 90% of the time, that's not what they mean. But it attaches that negative correlation to people who work with those things, struggle with those things on the day-to-day. And they're not, as a rule, overall dangerous people.
Right.
So having the two get lumped together kind of perpetuates that misunderstanding, I think. Whereas
can you explain a little bit what's the difference between...
Oh, well...
Is there an easy way to explain that?
I think so. There's so someone who's psychotic is generally hallucinations and delusions.
Okay.
Someone who's a psychopath, you're looking at like antisocial personality disorder. So those are the people that in the most severe cases, you're hearing about serial killers and that they tend to be like the high end of the severe cases. So they tend to be, not interested in other people. They kind of see people as things.
Right.
They can be, not always, but can be dangerous. And so getting the two crossed over
can also be dangerous.
Yeah. And I mean, that might just be a pet peeve of mine, but I see that all the time. And I'm just like, oh my goodness. So I want to correct everybody.
Yeah. Well, and I think that's important because it is sometimes like, oh, don't be so psycho, or, in our language, we're being so careful around language now in every realm of society. And I think also with mental health, it needs to be started, a little bit more recognition as far as what words we're using to describe certain things.
Well, even anxiety and depression, I mean, we use those, and even I use those on kind of a day-to-day basis. And for most of us, when we think anxiety, we think of just your day-to-day anxiety. But the problem with that is then when someone's actually suffering with an anxiety disorder, we assume when you say anxiety disorder, it's the same thing that I feel when I'm going to go do something new and I'm a little uncomfortable. And, then you get the just push through it. Just do it. I mean, I don't understand why this is such an issue. I'm fine with my anxiety, and that's very hard on people who actually have the diagnosis because, I mean, everyday anxiety is actually in a different part of the brain than anxiety for someone with an anxiety disorder. Okay. And so it's very different, but because in our vernacular, it's the same, then the assumption is, well, this shouldn't be an issue for you. It's not an issue for me.
Yeah. Yeah. I know it's, and how to explain that to somebody who it's not an issue for, you can't.
Yeah.
You only know what you know and your experiences. And yeah, I like that perspective. I love that you put that one out there because we just don't, I don't think about it.
Yeah. Well, we assume that everybody's experience of reality is the same as ours.
Yeah.
And it really messes with your head when you start thinking it's not. Sometimes it's very, very different.
Yeah.
I think the one that when I used to teach, I used to use to kind of make my students think was that, the only reason we know when we look at something and the color, we label it as, say, blue. We all label a certain thing as blue. But because colors are waves that hit our eyes, the only reason we know that is blue is somebody taught us.
Right.
I could be seeing a completely different color than you. and you're labeling it as blue and I'm labeling it as blue is because somebody pointed at it and said that's blue.
Right.
You know, but there's no way to know if we're seeing the same color or not.
Mm-hmm.
And I think that just even in that, like people's experiences so vary that it's impossible to really, that's why in psychology everything's correlation and not causality, because it's so impossible to make predictions with 100% certainty because people vary.
And that's the fascinating part about psychology, though, is that there really is, like, you're constantly learning just by people's behaviors. And I mean, I guess, is there more, like, the research coming up now as far as treatments and for various different things? Is there leaps and bounds between the last 10 years and, say, the last 50? Or is it still just a slow and steady observation of
I think it depends on your area of research, because there are certain areas where there have been leaps and bounds due to technology. So, like, let's say for phobias, we can work with them in ways now using virtual reality that we couldn't 10 years ago. And so that opens up new areas to kind of explore as far as research goes. When you're looking at, like, the new treatment coming out for post-traumatic stress disorder, there's, I think, just one in the city right now. It's called EMDR, and it uses technology to help. Right now they're focusing on veterans, but to help process PTSD experiences. And again, that allows us to put in pieces such as, visual images, sounds, movement that we couldn't have put in before because the technology wasn't there. Even right down to now, we can see things genetically better. We can look at, different types of medication and kind of what does what and how they interact. And, so those pieces are moving forward relatively quickly. When it comes to the examination of human behavior in and of itself, that tends to plod along at its own pace, because there's not much
change in the social structure of everything too. Now you've added in social media. I keep talking about that, but I mean, it changes, I would think, all the time.
Oh yeah, definitely.
Surroundings.
Yeah, definitely. Social psychology changes all the time. When you're looking at interactions, like even since COVID, pre-COVID, no psychologist or very few psychologists did virtual sessions or over the phone. Most of us said, well, no, we can't make that work. But then all of a sudden COVID happened and we all had to switch. And now, like, everybody does it. And nobody has a challenge with it. Because psychologists, just like everybody else, we're not big into change. But when you have to do it, you have to do it. And so we adapt, and then all of a sudden now we're doing a lot more studies and things into telepsychology, for example. So
telepsychology.
Yeah, so over the phone or over Zoom.
I just haven't heard it put that way before.
Oh yeah, that's the in the official terminology for things. That's what they tend to call it. But it's more like, well, is there a difference in session outcome? In in person versus over a medium. And prior to everybody doing psychology over a medium, there, how would you ever know? There's like so few, but now you can really compare. So
So I've had a few people ask me to and I haven't been able to speak to anybody yet that can share a little bit about what EMDR is and what are the benefits.
So EMDR can actually benefit a lot of people. EMDR stands for eye movement desensitization and reprocessing. The confusing piece for some people is it doesn't actually have to be eye movement. It's just when they first developed it, that's where the focus was. And so the theory behind EMDR, and we don't have an exact explanation for why it works. So you're not going to find one, but there's some theories. And one of them is that when something happens to us that is very traumatic, and we're talking like your big T traumas, which are, sexual assaults or something like that, and your little T traumas. So those are things that happen to us that just hurt and we can't shake, even if we try. For some reason, they're stuck.
Right.
The theory is that when our mind stores a memory, normally what happens is, if you think about it like a library, the memory comes into the front desk, and the front desk sends the emotional part of the memory to one side or one area of the brain and the facts to another. And so then the emotional side gets processed and worked through, and the emotion tends to diminish. And then the part of our brain that processes the information will store it away in our memory library, let's say. And so when you think to something like your best birthday ever, you remember kind of being happy, but it's not as intense as when your birthday happened, because your memory's done its job. Now, when something traumatic happens, it's like it all hits that front librarian at once. And that librarian goes, well, I don't know what to do with this. So it just throws it all over to the part of your brain that processes information, which it doesn't know what to do with the emotions part of it. So they just kind of get stuck in there.
Yeah.
And so your mind's trying to, store this in your memory, but because the emotions are in there, it can't fit it into its bookshelf. So it just sort of throws it over its shoulder somewhere. And so you're going through life and you're experiencing and you're falling over this. So you're on the bus and all of a sudden, you smell something and you're triggered right back to that memory. You've just sort of fallen over it in the course of your day because it's not where you need it to be. It's just kind of cluttering your floor.
Yeah.
And so what EMDR does is, by activating the emotion and the memory and then working through the process, it will reprocess that through correctly. So that the emotion gets processed by the emotion part of your brain, and then the facts get processed by the fact side of your brain. And then by doing that, the emotionality of the memory diminishes a great deal, and you can kind of shelve it where it needs to be, and you can go access it when you want to.
Right.
So that's one of the theories behind it. So basically what it looks like is there's different protocols that you can follow to access different memories. But I will bring a person into session, and then if we're going to work on the EMDR, I get them to pick a memory that they want to work on, something that's really standing out in their mind that really bothers them. And there's a few other more specific processes we do with that. But basically, we're identifying the key memories. And then we scale the emotion associated with it. And, 0 to 10, where would you say it is? And then we will pick perhaps a negative belief about themselves that showed up at that point. And a couple other things. And then what you get them to do is sit with both feet on the floor. So it's important that people aren't all crossed up, because you're working with brain hemispheres. And so anything that you can use to stimulate one hemisphere of the brain and then the other, while they're focused on this memory and activating that emotion, is going to cause reprocessing to happen. And so you can stimulate, and it sounds really impressive, but it's really not that difficult, because you can stimulate one side of the brain and then the other based on interaction with one hemisphere of the body and then the other. So the eye movements, basically you're going back and forth so that the eyes move from one side all the way back to the other. Or you can tap on one knee and then tap on the other back and forth. You can use sound. Some people have a light bar that goes back and forth. Buzzers. So you hold buzzers one hand and the other. I prefer to use the eye movement just because it tends to process faster, and I have a few other options there if something gets stuck.
Right.
So it allows for a little more variability, but it's not the only way to do it. And so you work through a process with them, checking in with the memory, looking at the emotion, seeing where the mind goes to. And there's a few different types that you can do, depending on your goal. And then eventually you work your way along to where the emotion has almost hit a zero. And at that point, then when they recall the memory, it doesn't it doesn't bother them anymore.
Right. And so, okay, I've experienced EMDR myself,
Mhm.
and it's fascinating to me. And I leave each one thinking, well, what just happened?
Mhm.
I don't understand this.
Yeah, I get a lot of that.
Yeah.
Like, people will just all of a sudden look at me and go, why doesn't this bother me anymore? What's going
Right.
on? You know?
Yeah.
Because your brain just does what it needs
It's almost
to do.
like it's like you're trying to find it again, like you're searching to find,
Yeah.
almost like a puzzle.
Yeah.
Or a maze or something, and you can't go back and find that memory as well. Like, you can still remember it, but
yeah. One of the things, actually, interestingly, that the trainer that I went to told us is that you're not supposed to do EMDR before someone who has to go to court and testify.
Oh.
Because it takes the emotion out of the memory. And so when they're recounting what happens, there's not the same emotionality to it. And so the jury reads that as this wasn't as serious as it was.
Yeah, interesting.
And so in any sort of case like that, I always check if we're working with a big T trauma.
Mm-hmm.
You know, I'll say, okay, so have you done everything you need to do with this before we actually work on the emotion?
Right, because that is important. It is important if you're trying to,
Yeah. And there's a few other things you can do too. Like, you can kind of forward treat things. So let's say there's a flight phobia.
Mm-hmm.
If we can access the emotion during the session, we can work on the flight phobia and the expectations of the phobia, and we can diminish the emotion around that. So that, you know, you're not going to feel the same way that you do normally when you get on the flight.
Right.
You know, there's a few other things you can do with it. So it's not just confined to major traumas and things.
Mm-hmm. Yeah, I was going to say it can be used, like you said, on many different, like almost anybody could probably benefit in some degree.
Oh, yeah.
Yeah.
Yeah. You know, we look at memories that are networked. And so sometimes the first memory that you're struggling with, it might be networked to things in the past that, you know, you're not even aware of, but your mind will take you there automatically. So the difference between EMDR and, say, like recovered memories, which isn't something that psychologists use anymore because there's all sorts of research into that not being a thing.
Okay.
But with this, because we're not influencing, we're not asking you to find anything, we're not even telling you what you're looking for. We're just asking, you know, what comes to mind.
Yeah.
And then it can be anything. And sometimes, you know, it ends up places where the person doesn't expect.
Yeah, you don't even, sometimes you're like, how did that even come up?
Mm-hmm.
Yeah.
Yeah.
And it might not even be anything important.
Yeah.
Or that you would have thought would be important.
Yeah, absolutely.
Yeah.
It's fascinating. I'm always amazed by the process when someone walks out and is feeling so much better. And for some people, it happens very quickly.
Right.
Especially if it's a recent memory. If we're dealing with a child, for example, and it's a recent memory, then it'll process quickly. If you're, 80 years old and it's a memory from when you were 2, it's going to take a lot more work.
Interesting too. And that's actually something that people should know about. If your child has been through something traumatic, that's something that you could, now, is there enough research behind it that it stays away? Is there any, does it ever come back to the same degree, or?
Depends on who you read. There's not a lot of research saying it comes back.
Yeah.
I mean, you could, if you worked hard enough at it, reactivate it.
Yeah.
So if you started dwelling on it and intentionally bringing up how you felt and recreating the situation in your mind, you could probably get there.
Yeah.
But most people, that's not their goal.
Right.
Their goal is to kind of put it to bed, so to speak. And so the majority of the research, as far as I'm aware, suggests that it does stay gone.
Right.
One of the reasons I like it, actually, is it's one of the less painful ways of dealing with trauma. Because, the cognitive behavioral therapy method of dealing with trauma is to have you recount it 100 million times.
Yes.
And that's hard for people. They don't like that. And sometimes people don't want to tell me everything, and that's okay. You don't have to tell me everything in EMDR. It's just a snapshot of what kind of represents this situation to you. And then you don't have to get into the nitty gritty with me.
Yeah.
Whereas with some of the more traditional therapies, you do.
Yeah, you're deep down into, yeah.
Yeah.
And so is that a safe practice then for kids?
Oh, yeah.
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 Okay. It's just done in a different way probably. And
Yeah.
made, yeah.
Yeah, it's done in a little different way because kids process information a little bit differently. So I've seen it done with play therapy where they've put like I think they put the buzzers in the back of their shoes, if I remember properly.
Okay.
And then the child was reenacting with play therapy what had happened.
Right.
But they didn't have to like actively recount anything because when you do play therapy, generally they play out the traumatic situation. I've never done it personally because I work usually 15 and up.
Okay.
But I do know people who do those things.
Can I just ask what if there's a sexual assault or something that happened as a teenager then, for instance, is it something that if you, again, get to right away, that you could really kind of nip that trauma later on and suffering with that later on in life?
Yeah.
That is something that you can...
Yeah. There's something called a current events protocol, which is technically like recent events, because it takes a while for our memories to network. So if I'm going to do a full EMDR protocol, then I'm working with a memory network that's already built. Okay. So something has happened and it's networked itself to this other thing, which networked itself to this other thing. If I get in there fast enough, then I don't have to worry about the memory network because it hasn't built yet. Right. So I can just work through the event as it happened. Do a slightly modified version, but then that memory network doesn't build with that in it.
Right. Okay. Oh, wow.
Yeah.
You know, and I mean, honestly, unless I'd gone through my own trauma and they recommended EMDR, I wouldn't know about it. And as a parent, to know that that's a possibility to ease the pain of your child or, you know, a loved one or a sister or whoever, you know, a friend, like this is what you could do to possibly take away some of that pain.
Oh, absolutely. Yeah. I mean, it's like any other psychological therapy in terms of it doesn't necessarily work 100% of the time.
Yeah.
But a good chunk of the time. And a very ethical therapist is going to tell you if they're not getting in where they need to get in. They're not just going to drag you through the process.
Right. Yeah. But it's just another alternative that people might not even be aware of.
Yeah. There's a lot of therapies people aren't necessarily aware of.
Definitely.
Because, you know, we don't walk around saying, oh, by the way, I can do this.
Yeah. Yeah.
I know for me with the EMDR, I do some clinical hypnosis. I'm not an expert in it by any means.
I was going to ask you about that, actually. Yeah.
Yeah. I've had some training in it. And so I often will use that in combination with the EMDR in certain types of situations. I found that the two of those complement each other quite well.
Yeah, yeah. Interesting. It's so fascinating. I say this all the time. I just every show I get the chills, and I just want to know more, and I could just talk about it over and over and over. Is there any other therapies that you could really highlight or that you would want to highlight that you found have been the most beneficial? Or is it just a matter of, like you said, depending on the situation, what's the best for that person?
Yeah, there's going to be a lot of factors as to what's beneficial for a person. Some people really enjoy psychodynamic psychotherapy, and that's what you think of like the old school kind of, you know, exploring your relationship with your mother. And, you know, it's kind of more Freudian almost.
Is it always mom's fault?
No, it's not.
Okay.
The only reason to this point that it's usually mom is because to this point in our society, mom is usually the one with the kids.
Right.
So if you're with the kids the majority of the time, then you're likely going to be the one that shows up a lot.
Yeah.
But other than that, you know, it just happens to be. But some people really enjoy that because they really want to get back and dig. There's a lot of the psychologists at Soujourn here, they do EFT. Okay. I don't know a whole lot about it, but people find that very beneficial as well. It's emotion focused therapy.
Okay.
I also do family systems therapy, which is it's a concept that when we encounter something traumatic, it's like we split off that aspect of ourselves.
Yeah.
and we kind of distance it away because we don't want to deal with it. But then because that aspect of ourselves is split off from the main self, it kind of gets stuck at the age that it is.
Okay.
And so the work is towards kind of reintegrating that aspect with the whole self. But that's the reason why, like, for some people, when their trauma gets triggered, all of a sudden their behavior will drop to like a 5-year-old, and they'll start maybe tantruming, or, you know, their verbal responses become very childlike. And it's like, okay, yeah, you know, you've dropped into this age, probably. And I found that really useful because if you think about it, we do talk about ourselves in parts quite often. You know, part of me wants this for supper, but part of me wants that for supper, you know?
Yeah.
So it's different from, say, like dissociative identity, which used to be multiple personality disorders. That's a very different thing. This is like, you know, it's parts of the self. It's not a different self.
Right.
But yeah, I find that for some people it really connects and really makes a difference.
Yeah. And so that's, you bring up an interesting point, because I've just started to learn about, I've just started to learn about all of that myself, as far as, you know, okay, so something traumatic happens when you're 12, and is that kind of where, like, you're not stunted at that age? This is where I'm a little confused by the whole, the theory behind that.
Yeah, you're not stuck at that age. There's an aspect of you
Of
that
yourself.
is.
Yeah.
And so whenever that trauma is triggered, you may slide into kind of reactions that might be, you know, associated with that age.
Okay.
So it might be might be when you're a teenager, and normally you're a very, you know, laid back kind of person, but when your trauma gets triggered, all of a sudden you get really obstinate and really, you know, kind of rebellious, like a teenager would be.
Okay.
But then when the when the event that triggered it has passed, you're back to being who you are. So it's not like, you know, you're stuck at like 5 years old.
Yeah.
You know, you still grow and develop. It's just this little aspect of you is isolated and kind of walled off to manage the trauma, really.
Right. It's a safety. It's stuck back there for a reason. Yeah. And then comes out when,
whenever it's triggered or something kind of gets past your defenses, then there it is.
Oh, that's fascinating.
Yes. So the analogy of EMDR, when I'm describing it to people, as it might be a good idea, is I'll tell them it's like you have this bucket of yucky stuff in the corner, and you are doing everything you can to just pretend it's not there. You don't want to look at it. You don't want to think about it. As long as it just stays in the corner, you're fine. And then I come along and I say, hey, let's bring that to the middle of the room and let's dig around in it. Let's see what we find in all this yucky stuff. And I mean, people are like, but I don't want that. Like, I don't want to look at that again, which makes sense. I mean, you just want to like, no. And so sometimes there can be a little bit of reluctance, or sometimes even some anxiety, because I mean, who really wants to go back and look at all of those memories in any sort of detail at all? You know, I mean, it's only a problem when they get triggered. So most of the time, for most people, you can ignore it until it becomes an issue.
Right. But if this helps that when you get triggered and people understand that.
Yeah, you can make it go away completely, or you can ignore it and it's going to jump up on you whenever it feels like it. But that was an analogy that somebody, I can't remember who told me that, but I thought, what a good explanation. Because like, no, you don't want to look at that.
Because it's not a tangible thing. You can't just, and I'm sure it works different for everybody too. Yeah. So there's all of those different factors. So I asked, this has been so awesome. I love the conversation, and I do want to ask a little bit about Soujourn, and what are some of the things that you guys offer here, and like where we can find you and all that stuff.
Okay. So for Soujourn, we offer quite a variety of things. We have couples therapy, we have family therapy here. For children, we have therapy for individual adults. You know, I do a little more clinical work as far as let's say someone has come out of hospital and needs some community support, or I'll work with addictions or with certain personality disorders just because of my background. There are other people that I'm kind of mentoring along in that have an interest, so they're getting much better at it.
Right.
But, we'll basically have people who will see a variety of individuals. Right now, we have someone for a limited time who's doing neurofeedback.
Okay.
It's something that I'm hoping to license in kind of down the road. And it's an alternative treatment for ADHD. They use it with autism, they use it with anxiety, and that's a whole nother conversation. But, that's something that we're offering right now. And then, like I said, down the road, I'm going to license in that as well. We have some people that work more somatically, so that's more like with body feelings and things. We have quite a few that work in an EFT type way of looking at things. But we also have some that are more CBT orientated. We have a variety of levels of experience here. Myself and Tara are probably two of the most experienced. There's one other I think that has more experience than we do, but tend to have, within like newer psychologists that we're mentoring along to people who are a little more established. We've also got a few that used to work for Alberta Health Services, so that's helpful because they also have a knowledge of the systems.
Which is really important, right?
And we also, there's certain people that will call and ask for psychologists of a certain religious persuasion. So, we have Christians who will offer some therapy. We have a Muslim person who would offer some therapy if the spiritual consistency between the client and the therapist is really important. And we do get those requests sometimes.
Right. That's actually really cool to know that. Yeah, because sometimes it can even just be based around spirituality.
Oh, absolutely. I mean, there's a bit of a difference between, let's say, what we would do and what someone doing more pastoral counseling would do. But if you have a shared understanding of religion or theory of the world, then you can incorporate that into the therapeutic process if you think that's something the client would be open to. But we have that. We have one male therapist right now. Sometimes we have more, sometimes we have none. But we do have one right now. And we will see people with insurance claims or people who are referred to us just from friends. You don't need like a doctor's referral to come see us. You can just give us a call. Probably the best way to do that is our website. It's just sojo.ca, and there's a listing of all our psychologists, what they do, kind of a little bit of a background on them, if that's something.
It's a really nice website, I have to say.
Oh, well, thank you.
It's easy to follow.
It being intuitive. That's one thing I learned from working for Alberta Health Services for so long, is their website is not intuitive in the least. At all. And so, being able to appreciate that is very easy to find your way around. One of the things that Soujourn has that not a lot of other clinics do have is that we have a front desk administration that's here for all our opening hours.
Right.
And so when you phone on the hours that we're open, you're going to get somebody every time you call. So you're not going to get an answering machine telling you that, we'll call you back. You can call and you can book whenever we're open.
That's nice.
And the ladies at the front desk are very good at, what's kind of the basic issues. They can match you with a psychologist that they think is going to be able to best treat what you're concerned about. And then they'll schedule you up, get you in as soon as possible, put you on our wait list if you need.
Right.
So that's something that we offer that not a lot of other places do.
It is. It's surprising now, hey? It is, and it's because everything's online or it's automated and it is nice to talk to somebody.
Well, I definitely know, like when I'm looking for a psychologist, because every good psychologist has a psychologist.
Of course, yes.
When I'm looking, I tend to go towards the one where I know somebody's going to pick up, because I don't like just phoning and leaving random answering machine messages everywhere. And that might just be a me thing, but I'm sure there's a few other people that would like that as well, just
Yeah.
to get it dealt with as soon as you call.
Mhm.
We do interact via email as well, but we
Okay.
tend to, because psychologists, we don't check our email as often during the day.
Mhm.
We tend to route it through one email address at our admin desk, so
Right.
they don't read it. It can be password protected if necessary, but they just forward it on. So then if you answer back, they can, come find us and be like, hey, check your email.
Yeah.
It gets you a better response.
They can get a hold of you somehow in some way.
Absolutely. And I guess if you're not aware of where we actually are located, we're in Sherwood Park, Alberta. So just off of Anthony Henday and just a little off of Baseline. So you don't have to actually go deep into Sherwood Park to find us, which is nice.
So do you offer, and I often wondered this, it's great to have it in the community, but because everything can be done virtually, do you have clients that are not in this local area?
Oh, yeah. Absolutely. I have, so as a psychologist, we're restricted to see clients that are located in Alberta.
Okay.
And that's just how our licensing system works, how our insurance system works. And so a lot of people think, well, if the psychologist is in Alberta, you should be able to just, talk to somebody wherever, which intuitively seems to make more sense. But it has to be that the client is located in Alberta.
Right.
And so as long as you're anywhere in Alberta, we get people that drive in here from Vegreville. We get people from, some of the other small towns around. But I have some clients that are like, say, in Fort McMurray or some places even a little farther north.
And EMDR can be done virtually.
Yeah, it definitely can. Depending on the practitioner. It's something I'm working to master. to do it virtually. Yeah. But there are people who are definitely really good at it. We have several people here who do offer the EMDR. But if you're not in the area to approach Soujourn, or if you're looking for something more virtual and we can't get you in, you want to make sure you go to the EMDR international website and you can find a list of licensed practitioners, because not everybody who does it is licensed. You need somebody who's licensed. Right. And there's 3 levels of licensing. There's basic, and then there's just just lost the name of the second one. But anyhow, there's like your mid-level practitioner.
And they'll let you know what those are.
Yeah, it says behind everybody's name where they're at. So you can pick where in North America you actually want it. If you're on the Canadian one, it's called M.E.d, so it's like EMDR, I think. IA, I think is how it's spelled. Okay. Then you see all over Canada. And who offers.
Well, yeah, and is that one of them that you can just get like a certification for now?
No, that one you have to do. No, that one you have to do. So you have to do a week's worth of training, and then you have to take a period of time where you're supervised. Okay. And then you have to do another week's worth of training to get your basic. Right. To get your second level, you have to do a certain number of hours supervised by a consultant. So it's not a lot of additional intensive training, like you're learning different techniques within it, but everything you do is supervised. Right. And then you get feedback constantly. And then when they feel like you are proficient, then they send a letter to M.E.d, and you get your second level. And then if you're a consultant, then you're someone who teaches. So you've got like years of experience, and they're the ones that are kind of probably the highest up on the hierarchy. So tapping is a new thing too, and I know we've been talking forever, but tapping is that sort of, does it in line with EMDR, or is it a totally different? So tapping comes out of EFT, if I remember correctly, and it's actually tapping different pressure points on the body. Okay. So I guess in terms of like physiological stimulation, it's probably the same, but it's actually like different pressure points that are supposed to I think it's related to kind of acupuncture zones, if I remember correctly. I don't necessarily know how to do it, but I know kind of it. I've done some research into it. And so the idea is that by tapping those pressure points, you can release the tension within them.
Okay.
Some people swear by it with anxiety, but you need somebody to teach you how to do it properly so you know exactly what you're aiming for. One of the newer things out there right now that kind of is similar to the EMDR stuff is the vagus nerve research.
Okay.
So like there's different areas that you can stimulate the vagus nerve, which is the nerve in the back of your neck, that ideally causes some down regulation, some calming.
Okay.
And I'm just starting to see that get a little more prevalent in the last like maybe 2 years. But there's growing numbers of different types of activities you can do to help with the polyvagal theory is what it's called.
Okay. Yeah. I've heard that quite a few times.
Yeah. So that's newer, but
yeah, so many things to talk about. But I do want to ask this question. I ask all my guests this question. What is one of the last best things that you do at the end of each day, every night before you go to bed?
Oh, before I go to bed. The last best thing I do. Well, generally my cat comes to snuggle with me.
Okay.
And he's big and he's orange and he's fat.
Oh, nice.
So we're in trouble with the vet, both of us, because it's never the cat's fault. That situation. But he likes to come and sit next to me on the bed, and he just sort of rolls over on his back and puts his belly in the air. And he puts his head on my shoulder and just purrs. And it's just, it's just a moment of where it's like, he's just perfectly happy. He's got no worries, no issues. He just wants to be there and love you. And so that I think is probably one of the best things I do before bed.
Yeah. And that's a lesson in being present and happy with where you're at.
Yes.
Right?
Yeah, absolutely.
Yeah. And what is his name or her name?
His name is Oliver.
Oliver. Oh,
yeah.
Nice.
Yeah.
Nice.
He's got the big feet. He's got like 24 toes, I think.
Oh, wow.
So he's got these mammoth feet and he's so clumsy.
Yeah. Well, that's awesome. I like that. And I love everybody's answers because they're always so different and what brings people joy and calm before they go to sleep. I like to hear it. It's awesome. Thank you so much again. Where can we find you on Instagram? Are you on Instagram, Facebook, all that stuff?
Yes, Soujourn is on Instagram. And we have a YouTube channel. So myself and Tara and a few of the other psychologists take turns putting out different types of information. I have a series on there, just like a few minutes on different mental health diagnoses, just to kind of explain them in more layman's terms, so to speak.
Right.
The Facebook, we do also have a Facebook page. And so if you look up Soujourn Psychology, will be the one that pops up.
Okay.
You're looking for purple and orange.
Yes, that's right.
That's the one that will be us.
Okay. Perfect. Thank you so much again for taking the time to share. You're a plethora, is that the right word, of knowledge. And I love it.
Oh, well, that's good. I hope it was helpful.
Yeah, it's been a pleasure for sure. Thank you.
You're welcome.
Okay, take care. Thank you so much for tuning in to today's episode. I really appreciate the time that I spent with Lisa. She's full of so much information, as I've said a few times. She's somebody that you might want to contact. She knows her stuff for sure, and she's such a caring person. If you would like to give me a follow, you can follow me on Instagram at carryonwithcarrie_podcast or on Facebook at carryonwithcarrie podcast. My podcast is available on Spotify, Amazon Music, Apple Podcasts, and now YouTube. My goal in this is to help others, and you never know who it's going to affect. So share and give me your feedback. Let me know what you want to hear about. What do you think really needs to be focused on right now? Or that's just important to you. I hope you all enjoy. And for now, I'm hoping we help just one person at a time.